All right, welcome to the Northwest Ohio EMS BLS guidelines for the St. Vincent's Island Ambulance Service. You guys are part of the Northwest Ohio EMS Consortium, where the purpose and scope for the guidelines and everything else is going to be an update and also training. We've gone away from the term protocols to guidelines for the simple fact that the majority of the stuff that you guys do in the near future within the consortium, it's not a rigid, you can't follow it, XYZ. So we do give you guys a little bit of leeway and play to be able to do some stuff. Of course, with this, the expectation is that you work within the guidelines. We do not. Uh, oh, things going off. Work within the guidelines, and then from there, perform your duties. And I have one simple rule, and that rule is to keep me out of the courtroom. So as long as you're not going into way left field or freelancing on your own, if you can do what's appropriate for patient care, then we will protect you and go from there. How the guidelines are broken up: tab 1 is the operational, tab 2 is the cardiac, tab 3 is the adult medical, tab 4 is the OBGYN, tab 5 is the pediatrics, tab 6 environmental, tab 7 is trauma, tab 8 is all the medical procedures that we allow you guys to do, and the last tab 9 is all the medications that you guys as EMTs can administer. Of course, if there's any advanced EMTs, paramedics there will be a separate guideline review that you'll need to watch online. And that's what I was showing Greg earlier. Any questions on this so far? All right. With that being said, in the operational, there's 3 medical directors currently for the consortium for the islands. Myself, Dr. Newmeyer, and Dr. White. You guys will see Dr. Newmeyer and White a little bit more. Dr. Newmeyer works down at Mercy Perrysburg and then Mercy Defiance. Dr. White works over at Wood County Hospital. So they come back and forth on all that stuff. The initial tab 1 is just pretty much all the definitions. What are the guidelines? What's a patient? What's intoxication? What's a policy? What's an assessment and all that stuff. Under the policy and the expectations, as EMTs, we expect you guys to maintain a BLS certificate. From that aspect, if you're an advanced EMT or paramedic, of course we expect you to maintain an ACLS, PALS, along with BLS. So that's for more for the paramedics. Advanced EMT is just the BLS certificate. The remainder of this, of course, is just assessment, treatment, document. Just remember, everything that we do needs to be documented. Greg will show you guys the EMS charts, how to use the EMS charts, which is a wonderful system. I can get online and review things and all that stuff. And then the last piece is just the standard of care. All patients should have primary survey, vital signs, chief complaint, allergies, and all that stuff. Tab 2 is the EMS scope of practice. If you have not reviewed the scope of practice since April of last year, you'd need to. If you don't know what you can do, then it's kind of hard to perform your duties, which in turn has problems with me, potentially going into the court. Again, I'm going to reiterate that multiple times. We do allow you guys to practice and function at your level of certificate. So if you're an EMT, I expect you to know how to do putting an EKG on, how to do tracheostomy care and all that stuff. So if you haven't done that before, we'll get some training and go from there. Tab 3 is the documentation. This is a new guideline that's been added in, and it's really from the aspect of expectation-wise. The big 3, your pulse, blood pressure, and respiratory rate, the initial ones should be and must be manual. Okay? Get and maintain a normal respiratory rate, or whatever the respiratory rate is, blood pressure, and then pulse and all that stuff. All right. So often I see that a respiratory rate is 18 documented on someone that's in shortness of breath, that in turn gets intubated. There's no way that could be an 18. So don't fudge the numbers and all that stuff. Right. The rest of the stuff, of course, your pulse ox, your temperature, NTO2. We're trying to get you guys new monitors, so in the future with cardiac, your carbon monoxide poisoning and all that stuff, to be able to assess other things. In tab 4, or tab 1 guideline 4, this is just the ALS side. You guys do have the fortunate benefit with being on the island of always having ALS pretty much there at your fingertips. Of course, sometimes if you're working over on middle bass, this might not be, and you might be the, one of the primary people working with or having to call for ALS. Of course, this is just the criteria that we kind of sort of look at. Does not mean that it's going to be an ALS transport, but more along the lines of ALS evaluation, and then they can determine, what are the further treatments and all that stuff, and go from there. Do have on the bottom section of this though, if ALS care is started or is being performed, then the expectation is that the advanced EMT and the paramedic will ride and perform all the documentations and all that stuff necessary. If everyone's okay and they feel that the patient can go by BLS, then of course documentation and transport from that. Questions on any of that? All right. Patient dispositions pretty much is broken up into 3 or 4 different categories. The big one, of course, is the emergent. Most of the items, if it is an emergent, it's going to be flown off the island. So your unstable airways, STEMI strokes, and trauma patients and all that stuff. I know that Greg will be talking with you guys in the near future about the clinic that is being proposed and worked on right now. So some of the stuff has the potential of coming back to the clinic where a physician and or nurse practitioner, PA, will assess the patient and then care for those patients. Of course, sometimes there might be the potential of, well, this patient really needs to go to a higher level of care, and right now the jurisprudence section that I have with Greg is, if he feels and the paramedic feels that the patient needs to be flown, then there's nothing stopping you guys from flying the patient. I don't care what this doctor or nurse practitioner has to say. Rest of it is just emergent, non-emergent, special cases and considerations and all that stuff. There is the section a little bit here where you have the no patient contact, no incident. Sometimes somebody else calls. The police officers might call and you go to assess, and really nobody wants EMS care. So from that aspect, I have no problem with you guys not performing a documentation. Now, if you do start care, if you obtain vital signs, if you touch that person, then there should be some form of documentation and or refusal release at the scene form written and prescribed and all that stuff. Questions? Quiet bunch today. There's the birds chirping in the background. Guideline 6 is just the transport places, a whole bunch of different places that we can go to. 7 is the activation of the air ambulance or the ICU, Coast Guard, and all that stuff. Traditionally, it's the paramedics that will be, and or Greg a lot of time will be the person that decides if the patient needs to be flown off the island and all that stuff. So working behind the scenes. If we do have problems and we can't get the patient off by helicopter, we do have all the information in here on how to obtain the Coast Guard. Usually you have to call over to Detroit Control Group, get permission from there, then call the Coast Guard ship commander, and then they'll send the vessel across. This can take some time, so if you got a really unstable patient, the patient, potentially, the helicopter a lot of times is a faster route. Communication, we do have all the different phone numbers for the local area, Life Flight, ProMedica Air, and all that stuff. And then at the very bottom, for online medical control. So the phone number that you might want to put into your cell phones and all that stuff is 419-251-4354. This is the phone number to St. Vincent's ER. They are always your default fallback medical control. Need to talk to somebody, and then from there, specifically a doctor and all that stuff, call there, ask for the attending, get online, introduce yourself, explain who you are, and then from that aspect, tell them either of course, tell them what's going on, and then if you already have a proposed idea of what you want to do, i.e., you have an asthma patient that you want to give albuterol to, say, hey, I want to be able to give albuterol 2.5 milligrams. Okay, go from there. All right. The medical legal side of this, pretty much broken into three things. Of course, the first is the consent and the mental capacity. Anyone over the age of 18, we have to get consent. Anyone under the age of 18, of course, it's already implied consent. And then half of this is based upon the person's mental capacity. In the EMS arena, we do not deal with mental competency. That is a lawyer judge term. Mental capacity is really broken up into three things. Do they understand what's going on? Do they understand the proposed treatment? And do they have sufficient emotional control to manage their own affairs? If they do, then of course they have mental capacity. Of course, this can always change depending on what is happening with the patient, okay? i.e., we have a diabetic patient that we give blood sugar. They initially don't have mental capacity. We give them some blood sugar. Now they do. It's the same thing like with your overdose, your heroin, and all that stuff. Initially, they don't have mental capacity. We give them naloxone. Now they do. So there's always some thought theories on how we treat and disposition of these patients. Always remember that we have a duty to act, and then confidentiality. Everything's HIPAA protected, and maintain it. I don't think anybody really has $100,000 to give to the federal government for a HIPAA violation. If you do, give it to me, and I'll hold it in a fund for you. I'll make some money off it. The other aspect is, well, sometimes, doc, we get this real good case, and we all learn by either bad cases or by someone else's mistake. What you do, if you want to discuss it, if you want to learn about it, you bring everybody in, you close the door, you lock the door, and you call it peer review. Okay? Under peer review, confidential information is protected by Ohio Law 4765.12. Okay? This will be a phrase that you guys will get used to. Under peer review, it's protected. The lawyers can't touch it. But afterwards, once you're done with the peer review, of course, you no longer are protected, and anything that you say or do can be a HIPAA violation. Okay. Any questions on that? Comments, concerns? Head shaking, yes, no? Okay. Tab 10, just the refusal treatments and then release at the scene. Most of the things that we do will be refusals of patient care. There will be some key scenarios, i.e., the respiratory distress, that you give them a breathing treatment, feels better. The diabetic, you give them some blood sugar, they feel better. The person that got tased, that is going to jail with a police officer. And of course all the simple, scrapes, bumps, bruises, stuff like that. Right now I'm still under the premise, if we give them naloxone, and they are truly adamantly about refusing transport and monitor, they need to sign a refusal. They're not going to be a release at the scene. Otherwise, most of the information is there. They should be alert oriented, not under the influence of alcohol, and all that stuff. And it talks about release at the scene, false callers, third parties, and all that stuff. In Guideline 11, the physician at the scene, and I'm not, and again, specifically not sure how this is going to be affecting us with this physician that's going to be at the clinic. Now, if this is going to be a family practice doctor that has no EMS experience at all, I'm going to try to kind of sort of shy him or her away from doing anything of online medical control. But remember, in the state of Ohio, doctors can be physicians on scene. Now, if it's a podiatrist, of course, just tell them to look at the patient's feet and keep going from there. Dentist, of course, they might, yeah, does he have a pretty smile? Okay, good from that. Otherwise, most of the stuff, the doctors, they can act as the med control. We do have on here the next piece. They should be able to show their current state of Ohio medical board license. Okay. Now, if they're if they have a state of Michigan license, guess what? Sorry, have a good day. You're not allowed to practice in the state of Ohio. We can't take med control from you. Of course, they have to go to the hospital. So it does not mean that, if they're going off the island, sorry, we're not going to guarantee you getting back on the island. You have to find your own way and all that stuff. Sign all the PCRs, and then from there, the majority of the time, their insurance or their malpractice insurance does not cover them. So if something were to happen to them or the patient, they could potentially get sued and be held liable for everything. So most doctors don't really do anything there. In Guideline 12, infection control, just remember, don't take the crap home. We are still working with Ebola. It's still out there. So anyone that's coughing up blood, of course, stay away from them. Wear your mask, N95s, goggles, gloves, and all that stuff. And then go from there. What now? In Guideline 13, this is the aspect of the practitioner disciplinary sign. So this is added in. So the first part of it, of course, is the Ohio law that says that you guys, as EMS providers, must work under a medical director, i.e. the EMS Consortium. And then from there it goes through the aspect if something were to happen, if you guys do something wrong, goes down the whole process of you're going to be notified, kind of sort of explain things, written, and then from that aspect, you'll sit down and talk with the medical director, and then from there, kind of sort of discuss things. If you don't like what was discussed, we kind of sort of have a repeat meeting in a couple days. And then ultimately the medical directors along with the chief will discuss things and come up with some form of action plan. Either remediation, warning, training, suspension, or even the permanent suspension and all that stuff. And at the bottom, if you're suspended from one department in the Ohio Consortium, you're suspended from all departments until otherwise noted. Now, this is where the rubber meets the road and all that stuff. The universal patient care. Everything else from this point on is going to stem from this. Of course, it's the initial scene safety, universal precautions, establish responsiveness, get your initial assessment, and then go to the appropriate guideline from there. Any of the airway procedures, obtain vital signs, consider your pulse ox, end-tidal CO2, carbon monoxide. Did add in here the consider ALS backup, and throughout the remainder of the guideline, that's going to be pretty much the second thing is really, do you need to consider ALS backup? Of course, you can do EKGs, and then go into the appropriate guidelines and or contacting med control. Any questions on tab 1? Nope. Okay. Tab 2 pretty much from the aspect the first initial part is going to be the chest pain, acute coronary syndrome, aspirin, and then from there assisting in obtaining 12 leads. As an EMT, we do not allow you guys to give nitro without med control order. And it's potentially the whole concern from you don't know if the patient is having a posterior inferior right-sided MI, that if you give them nitro, they're going to drop their blood pressure. And then, in the words of my old attending, we call that a clean kill. The other aspect, if the med control does allow you to give nitro, the minimal blood pressure has to be greater than 140 systolically. Anything less than 140, you don't give nitro at all. Otherwise, if the pressure drops below 90, and I meant to take that out because you guys aren't carrying the rescue guards out there. CHF, the main therapy for you guys will be the initiation of a CPAP. Start them off at 10 centimeters water, and then the majority of times they do well with this. 12 EKGs, and then transporting those patients. I forgot to say, in the legend, anything that's a white, an EMR can do. Anything that's green, an EMT. If it's a yellow, it's an advanced EMT. And the red for the paramedic. Of course, blue is all med control. Cardiogenic shock, nothing has really changed here. If the person's really looking bad, maintain airway. However you need to, get your 12 lead EKG, get your ALS, and then transporting these patients off the island. Cardiac arrest, the philosophy that we're having or going towards now is really working the cardiac arrest at the scene where the patient falls. Of course, this can be a little problematic depending on situations and all that stuff. You guys are now fortunate enough to have the Zoll auto pulse out there, which will make your life a whole lot easier when it comes to the aspect of the cardiac arrest and all that stuff. So, of course, the first aspect of it is, if they're dead, if they meet the DOA guidelines, not much to do from there. If they don't, begin chest compressions, rate of 100, attach your AEDs, airway management, and kind of sort of going down to the philosophy in the airway management of adopting something that's called cerebral resuscitation. So what they're doing with this is for the first 6 to 8 minutes, they're putting the patient on a non-rebreather, okay, and they're doing nothing more than chest compressions. If you have to feel like you need to do something, of course, you can bag them. Of course, in the scope of practice for a EMT, using any of the blind insertion airway devices, supraglottic devices, i.e. the King airway is the main one that we use. But don't stop chest compressions for any airway maneuvers, defibrillation, or anything like that. Well, actually, defibrillation is about the only time that you actually do stop chest compressions. In here, the first, again, this is talking about for the first 20 minutes, really want you working that patient, at the scene. Once we start transporting without an automated CPR device, we become 17% effective at doing good chest compressions. Which is the whole reason of why we do every minute and a half changing, rescuers, and really preventing rescuer fatigue and all that stuff, giving the person the best opportunity. Maternal rest, of course, always take care of mom, and she'll take care of the parasite inside of her. In the cardiac arrest pit crew, again, this goes with the whole philosophy of that we try to streamline the process so everyone has a position. Does this mean that this has to be followed, to the letter of the law? No, but ideally, I'm going to skip down to the actual diagram. Ideally, position 1 is on the right-hand side. They're the ones that's going to initiate chest compressions. The left-hand side, this person is attached in the AED. The top person is doing the King airway and getting ready to ventilate and all that stuff. And then if you have someone else that can record, of course, this can always be a police officer and all that stuff. If you look at the ALS guidelines versus the BLS, this is called the triangle. Okay? Within the triangle, basically from the waist up, there should not be an ALS provider. They don't need to put any additional airway stuff in. They can put their IVs in the legs, drill the patient, and all that stuff. They don't need to be pushing medications and interrupting chest compressions. Okay? The only two things that have been truly proven beneficial for someone in cardiac arrest is early defibrillation and good high quality CPR. All right? Any questions on that? Okay. Otherwise, cardiac arrest, hypothermia, from the aspect that no one is dead until they are warm and dead. Treat for hypothermia, cardiac arrest guidelines, and all that stuff. Do have in here a traumatic cardiac arrest. Pretty much the same thing. If the person is incompatible of life, of course, don't need to do much with them and let them go on to the afterlife. Otherwise, spinal mobilization, cardiac arrest guidelines. If you get return of spontaneous circulation, good. The ALS providers are actually instructed to get in early, at least trying to get a fast patches on to see if the patient is in asystole. If the person's in asystole in a traumatic arrest, nothing you're going to do, the person's dead. I do have a little bit of a bet that's going on for patients that are in truly documented cardiac arrest. No pulse trauma. If you get the person back and the patient walks out of the hospital, I'll buy you dinner. Okay? And the whole thing is, it rarely, if ever, happens. Just for the simple fact of how all the statistics and all that stuff. So, with someone in traumatic arrest, the chance of getting them back is less than 1%. Do we have here the AHA stuff, the BLS, the pediatrics, and then down to the DOA, dead on arrival guideline. All right. So is the person, do they have injuries incompatible with life? If yes, if they have any signs of decomposition, rigor mortis, then yes. They've been reliable down for 20 minutes without any resuscitating measures. Do they have any active DNR? Or do they meet the termination of resuscitations? If any of that is true, then we don't do anything further, contact med control, and let the person die. If they don't have any of those issues, of course, initiate resuscitations and then transport and all that stuff. In the termination, from the aspect, they must not meet any of the DNR guidelines. They don't meet anything for the dead on arrival guideline. If it's a blunt traumatic arrest, of course, it can be terminated if the cardiac monitor is there and the person's in asystole. And then all providers need to agree to discontinue resuscitation. If all that meets, then of course the requirements for termination, they've been without a vital signs for at least 20 minutes and no one has done anything for them. They must be non-hyperthermic. The AED does not advise a shock. If resuscitative measures were started, you need to work the patient for at least 20 minutes, knowing that there are some situations, specifically like with ventricular fibrillation and ventricular tachycardia, where they've actually gotten patients back at the 45 and 60 minutes. Okay? So the whole thought process there is, if they have a good end-tidal CO2 and they're just not getting back, yes, you might be working these patients for a long time. And then is there enough emotional support from the family and all that stuff? If they do, again, just contact med control. Let med control decide ultimately what to do. And if there's ever a case in doubt, of course, always initiate therapies and go from there. Guideline 11 is just the DNR stuff, all the definitions. And then, of course, we do have the paperwork of what, if you've never seen a DNR form and all that stuff. The biggest is they need to a doctor. This has to be a doctor. This cannot be a nurse practitioner. They need to either check the DNR, DNR-CC arrest, have the patient's name, and then from there, all this information here should be filled out. From there, again, they do the do not resuscitate or living will. The bottom information here must be filled out, ideally in a blue or black. Unfortunately, I have seen this written in crayon before, and that does not count. And then the LVAD for the left ventricular assist device. Just from the simple aspect that we might potentially have some patients coming on the island that do have an LVAD. If the LVAD goes bad, of course, CPR is always a last-ditch effort for them. Knowing that there's two tubes, one tube that goes into the heart, one tube comes out of the heart, you start doing chest compression on them, and the potential of the tube getting dislodged is pretty good. All right. Any questions on cardiac? All right. Adult medical. So from the aspect with the majority of the stuff in the adult medical will be very similar to the pediatric. So a lot of the stuff in the pediatrics we'll just be skipping through once we get down to that guideline. So just pay extra careful attention, all that stuff. In the abdominal pain, pretty much the aspect making MPO. Any signs of hypotension, of dehydration, of course, calling for ALS. If they're over 40, should be considering getting an EKG, specifically the older females, because they always present different and unique. So anyone with that, abdominal pain females or fatigue, should be getting EKGs and all that stuff. The alcohol intoxication, you guys that have not been on the island before will become masters of phoning friends and finding dispositions for intoxicated individuals. This guideline was created a couple years ago specifically for you guys on the island and all that stuff. Are they clinically intoxicated? Of course, there's always the question. You give me one margarita, I'm good to go. You give my wife a margarita and she's, under the table drooling and all that stuff. So it really varies from that aspect. So you can't take into consideration, well, I only had one beer, because one beer is exactly how many? 5, 6, 10? I only had one beer, but it's a 120 ounce beer. So. Otherwise, consider spinal mobilization, airway management, obtain blood sugar if need be. Does the person have any incapacitating intoxication? If they do, they need to be transported. And then the left-hand side, of course, in incapacitating intoxications, airway problems, they can't stand up, or they have any immediate risk environmental exposures and all that stuff. Do they have any illness or injuries? I mean, you're looking them over, they're seizing, they've had blood coming from their head, something like that, then of course they need to go to the hospital. If they don't have any of those issues, of these individuals, they can be referred to a friend, okay? It must be a sober friend, okay? Or family, police, they can take them to jail and all that stuff. In the allergic reactions, anaphylaxis, from the aspect broken up into 3 separate sections. Are they only having the dermatitis or rash versus are they having rash with a little bit of shortness of breath? Or lastly, are they actually in full-blown anaphylaxis having respiratory complications and all that stuff? For the rash, for the most part, not much that we do. For the respiratory distress, of course, albuterol 2.5 to 5 milligrams. It's split, if you look at it, green-blue, okay? In the state of Ohio, the scope of practice for an EMT, if it's for the medication, if the person has been on the medication before and or it's from their own medication stock, you do not need med control order as long as the medical director approves it. Okay, we approve it. From there, if it's the medication is coming from your stock, out of the airway bag and all that stuff, you're supposed to get med control authority first. All right, everyone understand that? Questions on that? All right. Otherwise, from there, EpiPen, still trying to work out some other things to try to cost manufacture. Most of the people aren't carrying EpiPens anymore just because they cost them $250. They're expensive. On the airway management, of course, any impending respiratory, ambulation, NPOPs, and if they have a full-blown, arrest, going to your blind insertion devices. Ultramental, from the aspect, again, universal patient care, ALS, spinal mobilization, airway management, checking the blood sugar. And then from there, depending on what the blood sugar, if it's low, giving them some blood sugar as long as they can swallow. And if their sugar comes up and they're doing well, those patients can be released at the scene. If they have a normal sugar, 60 to 250, think about other things, head trauma, overdoses, strokes, and all that stuff. And then from there, of course, if it's over 250, ALS providers, can give IV fluids and all that stuff. We do have in here the use of naloxone. So it's 0.5 to 4 milligrams inhaled for the EMRs and EMTs. All right. The two caveats: the person has had to have had a narcotic overdose, okay, and they need to have had respiratory depression. Now, if they're breathing 18 times a minute, does this person need naloxone? The answer would be no. Okay. This is point in times that you get a little bit of feedback. So these are the ones that pinpoint pupils. They're obtunded. They're breathing 4, 5, 6. That's when you give the naloxone. And it's low and slow. 0.5 milligrams inhaled. Okay, every minute, switching nairs. All right. So low and slow. You don't want to drive these patients into a post opiate withdrawal, which in turn can cause STEMIs and other problems with all that stuff. And then do have in here the release at the scene for the hypoglycemic patients, criteria, and all that stuff. Back pain is a new guideline for the previous crews and all that stuff. So ALS, if it's a trauma, of course, think about going through spinal mobilization and then transporting and dealing with appropriate guidelines. If they're having upper back pain, one of the potential concerns is for a thoracic dissection. So upper midline back pain, obtain bilateral arm pressures. If there's a 20 millimeter difference, that's when the dissection comes into play. Make them NPO, and those patients need to be transported as quickly as they can off the island. In the behavioral side, delirium, this is one of the new guidelines along with the psychiatric. So from the aspect, if they're having problems, phone friends, get a whole bunch of people there. And then from there, consider any of the other potential guidelines. Get them out of the stress environment, verbal techniques. A lot of times, we can talk them down as EMS providers. Unlike the police, they just don't like the police. So try to get the police backed up if need be. If you are going to take them down, 4 or 5 people, really from the aspect of, having friends available so that you guys do not get injured. Sometimes they can develop a cardiac condition depending on what they took or what's causing the behavioral excited delirium. So that's why no proning the patient, no hobble ties and all that stuff. Don't sandwich the person between backboards because of the whole aspect of the positional asphyxia, which is a bad thing. Dental pain is a new guideline. Of course, if it's suspicious for cardiac, obtaining the EKGs. If it's a multi-trauma, going to the appropriate trauma guidelines. If there's any bleeding, using direct pressure and all that stuff. And then from there, well, what do we do with the tooth? Okay, so if the tooth itself got avulsed, pulled completely out, you can either put it in milk, saline, or any of the other commercial products. Or the thing that I like to do is actually take it, kind of sort of figure out like a jigsaw puzzle where it's supposed to go back in, irrigate the roots, don't scrub the roots, okay, and then gently but firmly push the tooth back into the mouth. Okay. Yes, it will hurt, okay, the person, not you. And then from there, have them bite down on a rolled gauze or something like that. And that does two things. It stops the bleeding, and then from there, it stops them from talking. Did some tweaks with the dialysis renal failure this morning. So from the aspect, again, universal patient care, if they have a bleeding fistula, do anything and everything to stop the bleeding. Just putting a finger on it, bulky dressing, and then, of course, tourniquets. If they're having problems with CHF, going to the CHF guideline. If they're cardiac arrest, going to the cardiac arrest guidelines. And then from there, if they're not having any problems, of course, just let them go. Blood sugar's low, altered mental status guideline, and then if they had dialysis in the past 4 hours, one of the potential concerns is that they might need some fluid and all that stuff, which I really doubt that you're going to have anybody on the island that had just had dialysis within 4 hours. Epistaxis, just tilting the head forward using ice packs, compressing the nostril, and then determining, does the person need additional therapies? If they're extremely elevated blood pressure, they're anxious and stuff like that, the potential of actually stopping the nosebleed does not always occur, so might need to do some other therapies. Foreign body, just the simple aspect of abdominal thrust, chest compressions, everything that we're taught in ACLS and BLS and all that stuff. So just skip over that. Hypertensive emergency, this is obtaining blood pressures. Your ALS providers do have some additional therapies that they can give. So if it's systolic greater than 180 or diastolic greater than 110, getting your ALS providers there so that they can lower the blood pressure down and all that stuff. Hypotensive shock, if they're symptomatic versus non-symptomatic. If they're not symptomatic, of course, just observe and transport and go from there. If they're symptomatic, getting 12-lead EKGs, and then determining what is the cause of the reason for the hypotension and all that stuff. Is it trauma versus cardiac versus non-cardiac and all that stuff? In the influenza, from the aspect, of course, make sure that you protect yourself. PPEs, wearing your N95 masks, gloves and goggles and all that. And then kind of sort of determining, what does the patient need. If they're wheezing, of course, consider using a HEPA filter at the end of the aerosol circuit, so that you can, protect yourself, so that you don't get the flu like the patient and all that stuff. Otherwise, CPAP device, and go from there. If they're having sugar issues and all that stuff, giving glucose and then transporting and all that stuff. Poisoning overdoses, if they're altered, of course, think about sugar, think about naloxone, CO poisoning, so you have a house fire. Anytime that we have a house fire, we should always think about carbon monoxide poisoning and or cyanide poisoning. Cyanide a lot of times is the forgotten beast from a house fire and all that stuff. So really take that into consideration. CO poisoning is just giving them oxygen, CPAP, and all that stuff. If they've had organophosphate poisonings, of course, using the do don'ts. Otherwise, any other therapies and going from there. Do you have in here the phone number for? Yep.
Hey, what's your thought on trying to get him over to hyperbarics for CO?
Um, if you actually look at the literature now, there's very little difference between getting them to a hyperbaric chamber, washing the washing the CO out, versus using just high flow oxygen. The problem with the getting a patient to a hyperbaric chamber, there's very few in the area that you can actually dive the patient quickly. So that's why just using the CO. Now, if the person is, if they're really altered, if they're seizing, then of course those are quote unquote indications for using the hyperbaric chamber and all that stuff.
What would you be trying to dive him on though? Would you be trying to dive him on a 6 or a 6A?
Do what now?
What type of a table would you try to treat him on? Like a CO treatment table, or
Um,
that CO that
w-
CO chamber dive him?
well, yeah. I mean, there's always the you could try a CO, but the majority of them are still just using the typical dive, almost like a bends type thing, where you're giving them extra oxygen, and that's the whole thing.
Okay,
Is just you're trying to push the extra oxygen into the system.
but it'd be a modified 5 is what they're modified. Treatment table 5 is probably what they're diving him on.
Yeah, but the problem is in the area, like Toledo Hospital, it's being only used for the majority for wounds. So actually trying to get them in to dive them, it's going to take an hour to 2 hours to even think about that. And then if the person is altered or obtunded, then they're intubated, and a lot of the dive chambers themselves don't have the ability to have somebody in there monitoring them. Um, Flying them up to Michigan. I know that Cleveland occasionally has that. Columbus is the same way that they're not using the dive chambers anymore for diving. They're using it more for wound management.
Right. Well, I mean, with Toledo Hospital and even say St. Luke's, I mean, those are monoplace chambers that you really don't want to do a dive treatment anyways, or any type of treatment on those people.
Correct. Yeah. So
Uh,
the single bodies, and I'm not sure what Michigan has, and I'm not sure what Columbus has.
yeah, I don't remember. I mean, the reason I'm a dive medic too,
Okay.
um, so I kind of think about that a little bit differently from the treatment standpoint of
Yep.
actually being able to treat them.
Yeah.
So
Y-
okay, it was things we had at the fire department a couple years ago, and they never ended up. I guess Toledo tried to dive them, and it wasn't really all that good. And they were actually quite symptomatic, and I think they were I forget what the actual CO level in the house was when we took them out, but
Yeah.
no,
You. Yeah. Usually, if you can just, I mean, if they're really bad enough, just the whole process of intubating and putting them on 100% O2, that will clear them almost as fast as diving them.
okay.
Alrighty. And then just the rest of it, just some discussions and all that stuff. Psychiatric patient, very similar to the behavioral excited delirium, except with the aspect is the person having any anxiety attack. If they are, of course, think about verbal takedown or verbal techniques. Um, if they're suicidal, homicidal, depressed, do have in here the consider mental health slip. And when I originally put the guideline together, I misread the law and all that stuff, where I thought that EMS providers were allowed to perform mental health holds. Unfortunately, I went back and I reread the law where we in the pre-hospital arena cannot sign a pink slip. A police officer can sign it, but a EMS provider cannot. Of course, so it has to be a doctor or a police officer or something like that. But I still left this in here for the consideration. So if you have somebody that's homicidal, suicidal, having the police officer or contacting med control, and they can even do a verbal pink slip or something like that. Of course, then from there it also goes back to aspect: does the person have mental capacity? If they don't, then we automatically have the ability to transport and treat and all that stuff. The respiratory distress is very similar to the influenza from the aspect if they're having problems. Think about airway, think about your oxygen and all that stuff. If they're CHF, of course, going down to the CHF guideline. If they're wheezing, using the albuterol, CPAP, and then if they're back to baseline, they can be released. If not, transport and go from there. In the seizures, we modified the seizure guideline to kind of sort of include fever into this. So anything that needs to potentially cool the patient down. In the past, that we're always taught about, packing axilla growing behind the neck, and there's some literature that's coming out that you have a better reduction at fever or faster of putting ice on the palms, ice on the soles, and then on the cheeks. Of course, you can still use the axilla growing and all that stuff too. If the person is still having active seizures, of course, getting ALS there so that they can give their medications. Stroke, from the aspect of on the islands and all that stuff, immobilization, airway management, and then really knowing what is the time frame. Anything less than 3 hours, I don't really care where this patient goes to hospital-wise. All the ERs have the ability to give TPA, and then from there, if it's between the 3 to 12 hour time period, most of those patients are going to one of the larger institutions that have the neurointerventionalist, Cleveland, Toledo, Columbus, Michigan, something like that. That way they can do some additional special testing, perfusion scans, MRIs, and see if they need to do any of the clot removals or stuff like that. Always make sure that we check blood sugar. Nothing's worse than attempting to give a TPA to a patient that has a blood sugar of 30, and that was the cause of their stroking out type symptoms. And then transport and go from there. Do we have in here the fast, the speech time, all that stuff? Suspected abuse, just from the aspect is either physical or sexual, airway management. Make sure that you document. You pretty much guaranteed if you got a physical or sexual abuse case, there's a good chance that you'll be called into court. So document. In the syncope, very similar to the strokes and all that stuff, consider ALS. If they're complaining of numbness and weakness, going to the stroke guidelines. If they're having any spinal mobilization, check in blood sugar, cardiac monitor, and all that stuff. And then final, with the vomiting and diarrhea, just orthostatic pressures, blood sugars, and then transport. And then we do have in here a well person check. So sometimes you guys will be called out, the check safeties or the police officers kind of sort of want you to come over and check the patient to see if there's anything else that's going on. Of course, that's what we kind of sort of go from there. All right. Any questions on tab 3? All right. 4 is obstetrical. Just the first part is just the patient transport. Most of the OB transport should be lows and goes. Patients should be on the left lateral decubitus position and all that stuff. And from there, we do have the aspect of vaginal bleeding. The question is if were they pregnant or were they postpartum? This can probably be very similar to your dialysis patients. Probably won't have many patients that are postpartum. Or that they don't know and they're out drinking and they deliver in the bathroom or something like that. So there's some thought and theories, from that aspect. Do have in here the aspect of internal bimanual vaginal exams are not indicated in the field. All right. Do have to remind people for that. In the obstetrical emergency side, from the aspect of if they're a known pregnant or missed period, thinking about things like your preeclampsia and eclampsia. So if they're having high blood pressure and they're complaining of headaches, of course that's your preeclampsia. And then from there, if they're pregnant or even up to 4 weeks after pregnancy, 4 to 6 weeks after pregnancy, they can still have eclampsia. So any seizures 4 to 6 weeks after or during pregnancy, they need ALS because they need all the medications with all that stuff. If they are having abdominal pain but they're not pregnant, of course, think about abdominal pain guidelines. If they are pregnant and thinking about labor pains, then of course, having your catcher's mitt and being prepared to catch the baby. Fetal delivery, this is just kind of sort of, what we're already taught, not going to really talk about much with this. And then the procedures on how to deliver the baby and all that stuff. And the fetal delivery complications, your breech presentation versus the shoulder dystocia versus the prolapsed cord. And the prolapsed cord is, of course, think about, the mother, supine, anything and everything to really try to get the head off the cord. Putting them down into Nellenberg, having them putting their knees to their chest, or even putting the mother on all fours, like doggy style, and letting the head drop down because of gravity. Don't push the cord back in, of course, just wrap it up with saline and go from there. In the neonatal recess, of course, this is very similar to BLS, cardiac arrest. For the first 2 minutes, we as EMS, EMT providers, we do the neonatal resuscitation. Unless the child has meconium, it's all you guys. Warm, 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 sim, 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 dry, dry, dry. Wait 30 seconds. If they're not picking up, giving them some oxygen. Wait 30 seconds. If they're not picking up, doing your positive pressure ventilation. If they're not picking up, if heart rate less than 60, start chest compressions, and then or monitor from there. All right. So where's the ideal location for newborn babies to assess for heart rate? Hello? Anybody? Where should we check for a heart rate?
Brachial.
Brachial? Okay, what's a better place?
Femoral.
Umbilical. The umbilical cord. Check at the umbilical cord. All right. So that's the ideal place on the newborn babies. After you cross, clamp, and cut, the umbilical cord for the first day or so we'll take care of. All right, hold on a second, okay? All right. So neonate. All right. Any questions on OB? All right. Most of the stuff in the pediatrics kind of sort of do have the guidelines. So I teach a 1, 5, 10 rule. So a 1-year-old is approximately 10, 5-year-old is approximately 20, and a 9, 10-year-old is approximately 30 kilograms. Otherwise, most of the other stuff in here is just going to be for notifications and all that stuff. There's only really two major differences. Of course, from the aspect of it's all medications are weight-based, and then from there, the other two different guidelines is the ALTI one, which is the parent life threat, this is the kid that, mother says he was blue cyanotic limp, but the kid looks great to you. Nothing really to do, just assess the patient and monitor and go from there. Foreign body is the same as the your BLS, and for both for the infant, and then hypertension pretty much the same as the adults. And then the other different guideline, it will be the Operation Safe Haven or the infant abandonment. So the state of Ohio, for the first 30 days of life, any parent, any mother or dad that does not want the child any further, they can come drop the kid off to any of the EMS firehouses, and then no questions asked, just take the patient, contact your CSB, police, or whomever. Of course, if you can find out some information on the child, any medical problems, any history, when the child was born and all that stuff, it would be beneficial. But then from there, don't try to coerce or anything like that. Otherwise, the rest of the stuff is pretty much the same. It's just, again, just to reiterate, all weight-based for the kids and all that stuff. Questions on pediatrics? All right. All right. Into the home stretch. So for most part here with the bite and venomation, it's just kind of sort of figuring out dog bite versus rattlesnake anything. If they're having an allergic reaction, of course, using that guideline. Otherwise, transporting and going from there. In the burn section, do have in here the rules of 9 on the next page. Otherwise, if it's any thermal inhalation, of course, taking care of that, how we traditionally do burns. Chemical burns, of course, decontaminating the patient. And just remember, not everything likes water. Most powders, just brushing the powder off will take care of the problem. Anything into the eye, wash, 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 irrigate, irrigate, irrigate. Using a liter of fluids with nasal cannula, just flushing the eyes out as much as possible. And then, of course, into the electrical burns, cardiac guidelines. And remember, if the person was in a cardiac arrest, traditionally or typically you will get the patient back. And just as a reminder that the diaphragm is the last muscle, so you might have to breathe for them for quite some time. In the region, of course, St. Vincent's is the burn center. So all these patients from the island, all that stuff will go to St. Vincent's. Drownings and near drownings. From last year, this was modified. So the first section, of course, is the wake and learn what it kind of sort of looked like in the past. Otherwise, just try to encourage these patients, if they had a near drowning, to go to the hospital. Because they do have that second, the second drowning phenomenon, anywhere from 4 to 6 hours afterwards. If they're awake but altered, of course, thinking about other things, using CPAP if necessary, and then the unresponsive, do they have a pulse, no pulse? If they don't have a pulse, of course, cardiac arrest. If they do have a pulse, thinking about just simple airway maneuvers and going from there. Hypothermia is pretty much the same thing that we've treated patients in the past for hypothermia, and then hypothermia, not going to really discuss. We do a good job with all that stuff. Okay. Trauma guidelines for the most part. I'm not going to really discuss things. Do have in here the trauma criteria and all that stuff. The MCI start triage in the past previous guidelines, there used to be 2 separate guidelines, but we combined them together into one for the start triage and jump start. Just going through all the mass casualty incident stuff. Majority of the trauma, of course, load and go. Hemorrhage control. The ALS providers do have a medication on the island called TXA, so tranexamic acid. It's a medication that helps stabilize the fibrin clot. It does not cause clotting itself. It just stabilizes the fibrin clot, and the whole purpose of that, of course, is with the severe bleeding and all that stuff. So you guys as EMS providers, they might say, hey, give me the TXA or help me with the TXA, mixing it up and all that stuff. So go from there. Most of course, all the trauma stuff is just kind of sort of the same. I'm just going to skip down to the crush injuries. This will be the one potential thing for you guys as EMS. So you have that person that's crushed. They did have the winery, several years ago that fell down, and some people got crushed and all that stuff. So if they've been trapped or potentially trapped for up to 4 hours, anything after 4 hours, think about having an elevated potassium level. Actually, the process is called rhabdomyolysis, which is the breakdown of muscle. All right. So with that, up to 4 hours, or you're starting to get to the 4-hour time period, as EMS providers, using high-dose albuterol, 10 to 20 milligrams. Okay, 10 milligrams will drop your level by about 0.6. 20 milligrams will drop your potassium level by about 0.9596, somewhere in there. So the potential of helping out and all that stuff. Of course, the rest of the stuff is just a simple trauma, which I'm not going to really talk about anything from there. The last couple pieces, okay. I take that back. Pepper sprays, conducting energies. We added in the aspect of pepper spray into this guideline. So decontaminate the patient as best as possible, using whatever resources you have available. They've said milk in the past, whole milk or 2%, They've also said Johnson Johnson baby shampoo, Dawn dish soap. I don't know if I want to put Dawn dish soap in my eyes though. I don't know what would be worse. Um, any shortness of breath or wheezing, of course, use the respiratory guidelines. Any history of asthma or COPD, those patients should be monitored for at least 20 minutes. Otherwise, the conducted energies, if they're having any chest pain, palpitations, of course, cardiac monitor and assess having ALS there. If they're not having any problems, just hemorrhage control and then barb removals. Okay, as EMS providers, EMTs, you guys can remove a taser barb. Of course, the first thing that you want to do is make sure that you disconnect the gun from the box. Nothing worse than potentially getting shocked to yourself. And then otherwise, it's really just putting a hand down on the person's skin with a pair of pliers and pulling, yanking, pulling the barb out. Just a single barb and all that stuff. Of course, from the aspect, the 5 places down in the barb area, okay, if it is in their eyes, axilla, growing, breast, or the midline of their back, just leave it alone, cut it, and send those patients to the hospital and let the doctor deal with it. Hazmat and then weapons of mass destruction is the last one. All right. Questions on trauma?
Nope.
All right. So from here in tab 8, I'm not going to go through all this stuff. I'm just going to show this one and then the spinal mobilization guideline. All right. So certain key things that we want to be notified on, and ultimately I'm going to be having Greg. Actually, we can do this through EMS charts, where certain things that you guys click on it will notify us as medical directors immediately. Otherwise, just send us an email, give us a call, anything like that. If you send an email, there's this little phrase that we always use. Okay, confidential peer review information protected by Ohio Law 4765.12. Put that in the subject heading. Okay, don't put patient or patient information or whatever. Put the confidential peer review information protected by Ohio Law 4765.12. All right. That makes it peer review, okay, which means what? The lawyers can't touch it, which means it goes back to rule number 1, okay, keeping us out of the courtroom. That's what it's all about. If you intubate, LMAs, if you use the automated CPR devices, of course AEDs, or if you just happen to piss somebody off or someone pisses you off, let us know about it, okay? It's easier for us to deal with things proactive versus reactively. Questions on that? All right. And then we have all the procedures that you guys can think about doing intubations, LMAs, King LTs, capnographies in here, your rescue guards, rescue pods. Do we have in here scene rehab for you guys and the providers, EKGs, how to do it, automated CPR devices, rescue pods. The Zoll Auto is in there, but I want to get down to the spinal mobilization. All right. And again, the expectation is that everyone should watch the video on the spinal mobilization. All right. So the selective spinal. All right. This piece here, the first thing, of course, to take into consideration is the mechanism of injury. Okay. High-speed car accident. Someone takes a baseball bat to the head. Individual surfing onto the top of the golf cart gets thrown off. Yes, it does happen. If they're able to ambulate afterwards, great, no problem. Okay, they do not need a longboard. Okay, they still might need a cervical collar. So from that aspect, the questions to ask yourself is, okay, while someone is maintaining inline stabilization, the first question to ask is how old the person is. Okay, if they're above 2 or under 65, you can use these guidelines. Okay, if they're above 65, just put the patient in a cervical collar and transport. Okay, if they're under 2, they should be ideally in a car seat if there are any heavy traumas or something like that. Now, if it's a diving accident, the kid got dropped or something like that, yes, they might need to go into a cervical collar. Can the person reliably communicate? Meaning, you're talking English and they're talking Arabic. There's not a reliable communication. All right, put the person in a cervical collar. From there, looking at it, it's a 5-piece treatment algorithm. All right, the first one, or the mnemonic that we use, is NSAID, non-steroidal anti-inflammatory drug. That's what your ibuprofen is, and that's what your aspirin is. Okay. If a person meets all 5 of these things, which means that they do not need to go into the cervical collar, that's what I give them. I give them some ibuprofen to go home with. No, they do not give narcotics. I don't give them Dilaudid. Pat on the back and have a good day. All right. So the first thing is the neuro exam. So what you do is you have the person hold their arms out straight, pull their wrist back, spread their fingers. And what you do is then you push on their fingers and you push on their arm. Do they have good equal strength bilaterally? From there, have the person step on the gas pedal and pull up on their toes. Okay? If they have that, within 10 seconds, you did a quick motor skill assessment. All right? From there, touch the person from the feet all the way to the top of the head. They have sensation. And then the last piece to ask is, are they having numbness or tingling? So within 15 to 30 seconds, you can do a quick motor sensory examination. From there, again, while someone's maintaining inline stabilization, push on every piece of their midline spine. Are they having any spinal tenderness? If they are having spinal tenderness, of course, stop, put them in a cervical collar. Is the patient altered? Is the patient intoxicated? Okay. And then from there, are they having any distracting injuries? And the distracting injuries in the literature and the research is pretty much the thought process: a long bone fracture. They broke their femur. They broke their humerus. They got a sternal fracture. They had abdominal trauma. Okay. If they have any one of these issues, of course, put the person at least into a cervical collar. Okay, at minimum, put them in a cervical collar. Or you just don't feel, there's something in the back of your mind going, this just doesn't sound right. There's just something going on. When in doubt, what should we do? Okay, yes, put them in a cervical collar. All right. What? So the last piece, of course, coming down, and they'll talk about this in the video and all that stuff. Well, what do we do with the combative patient? That person, we put them in a cervical collar, they take it off. We try to put them again, and they start fighting us. They're fighting. Okay, stop. Just let the person be. Coach them onto the cot, okay, and then transport them accordingly. All right. They usually will take care of splinting themselves. And then after that, you need to make sure that you document. Document why you were unable to put the patient in a cervical collar. Okay? Document all your physical findings. All right? And then when you give report, do not tell them, well, the person was cleared by selective spinal mobilization. No, the person wasn't cleared. The person was fighting us, and thereby, in the best interest of the patient, we just left them out of the cervical collar. Okay? Again, the ideal thing, most patients should go into a cervical collar. All right? Yes, you'll have the occasional one or two that just they won't, and you can't go from there. All right. Any questions on any of that? No questions? Alrighty. So the last piece, of course, is just the medication guideline. I'm just going to kind of sort of, all the guideline, all the medications kind of sort of have it in here. We have the actions, the precautions, contraindications, any of the potential side effects, and then we have how it's set up as the adult and the pediatric dosages of the medications.